The first research will be presented by Dr. Marwa Saloma. She works in the Department of Rheumatology, Military Teaching Hospital, Tunis, Tunisia. And her work is about what are the associated factors with increased serum matrix metalloproteinase 3 in spondyloarthritis patients.
Assalamu alaikum. Thank you for your invitation. I'm delighted to be with you, and I have a big pleasure to present to you our study entitled What are the associated factors with increased serum matrix metalloproteinases 3 in spondyloarthritis? I have no conflict of interest. As known, spondyloarthritis is a chronic inflammatory rheumatic disease involving axial, enthesial, and peripheral joints. It can also be responsible for extra-articular manifestation, such as uveitis, psoriasis, and inflammatory bowel disease. Its prevalence ranges between 0.1 and 0.6% in MENA region. The physiopathology of spondyloarthritis is not fully understood. It seems to be multifactorial, including genetic predisposition, environmental factors, and interleukin-17, interleukin-23 axis, as shown by 2 published articles. The role of metalloproteinases has also been suggested. Metalloproteinases are enzymes of the proteolytic systems, and 23 human enzymes are identified. Metalloproteinases are secreted by macrophage, chondrocyte, and synoviocytes. Based on their biochemical properties, there are metalloproteinases are classified into 4 to 6 groups, as shown by our review articles. These enzymes degrade the component of the extracellular matrix macromolecule and are inhibited by endogenous inhibitors, especially the tissue inhibitors of metalloproteinases, also called TIMPs. These latter limit the excessive degradation of extracellular matrix. And under physiological condition, there is a balance between MMP and TIMPs. Several studies showed that patients with spondyloarthritis had increased levels of MMP3, suggesting a synergic action between pro-inflammatory cytokines and MMP3. However, data regarding the associated factor with increased MMP3 are scarce. Our study aimed to determine the associated factors with increased MMP3 levels in patients with spondyloarthritis. For this, we conducted a cross-sectional study in the rheumatology department of the Military Hospital of Tunis. We included patients with spondyloarthritis diagnosis according to the ASAS criteria. We did not include patients with chronic inflammatory bowel disease, autoimmune disease, asthma, neoplasia, and hematological diseases, and those with long-term corticosteroid treatment. We collected demographic data, spondyloarthritis characteristics such as the age at disease onset, the HLA-B27 stats, the structural the disease activity assessed by ASDAS and BASDAI, the structural damage by BASRAI, the functional impairment by BASFI, the axial mobility by BASMAI, and we also collected extra-articular manifestation and therapeutic management. For all patients, we measured ESR, CRP, and MMP3 using ELISA. Statistical analyses were performed using SPSS. These are our main results. We included 82 patients, 17 females and 65 males. The mean age was 45 years, and 45% of patients were smokers. The mean BMI was 24, and 39% of patients had BMI within normal range. Comorbidities were peptic ulcer disease in 9% of cases, hypertension and diabetes in 5% of cases. The mean disease duration was 7 years. Disease phenotype was ankylosing spondylitis in 66% of cases and psoriatic arthritis in 34% of cases. Axial manifestations were found in 82% and peripheral manifestation in 49% of cases. Extra-articular manifestations were found in 55% of cases, and HLA-B27 was positive in 68% of patients. Regarding the most prescribed drugs, the non-inflammatory, the non-steroidal anti-inflammatory drugs were the most prescribed, and CNF inhibitors were given in 26% of patients. Now, the mean ESR was 35 millimeter, the mean CRP was 20 milligram per liter, the mean ASDAS CRP was 2.9, and 60% of patients had active disease. The mean BASFI and BASMI were 4.2 and 3.1, and 72% of patients had BASRI over 3. Now, our study showed that patients with psoriatic arthritis had higher MMP level than ankylosing spondyloarthritis. And we found that MMP3 was raised in 37% of patients with ankylosing spondylitis, 53% of patients with psoriatic arthritis, and 42% of all patients. We found that MMP3 correlated to CRP, ESR, and ASDAS CRP. And in the univariate analysis, we found that associated factor with increased MMP3 were male gender, positive HLA-B27. However, CSG marks were associated with decreased levels of MMP3. In the multivariate analysis, we found that patients with positive HLA-B27 were 10 times more likely to have increased levels of MMP3. Now, the question remained, what is the link between MMP3 and HLA-B27? Today, the exact link between genetic predisposition and MMP in spondyloarthritis has not yet established. However, it has been suggested that the misfolding of HLA-B27, frequently seen in spondyloarthritis patients, is associated with a higher level of MMP3. Indeed, the accumulation of misfolded proteins in the endoplasmic reticulum can activate endoplasmic reticulum stress and orchestrate the unfolded protein response, causing release of pro-inflammatory cytokines and a production of MMP, especially MMP3 in joints. Now, regarding the link between MMP3 and spondyloarthritis characteristics, our results were consistent with previous study showing a correlation between MMP3 level and ESR, CRP, and disease activity scores. So to conclude, HLA-B27 is associated with increased level of serum MMP3 in spondyloarthritis patients. MMP3 seems to be implicated in the physiopathology of spondyloarthritis. However, further investigations about the link between MMP3 and genetic predisposition are necessary. And perhaps targeting MMP may be another therapeutic strategy in spondyloarthritis. Thank you for your attention.